Okay, good afternoon, everyone. This session is a live plenary session, but also people joining online. So I'd like to welcome anybody joining online. Recordings of this session, like all plenaries, will be available for 10 days, in 10 days' time on our online platform, details of which you should find in your conference brochure or login instructions. If you're watching online, you can put questions in the Q&A box underneath the live stream, and it will come to us on Slido. For those in Liverpool, please ask questions directly through Slido. Details are on the screen and will be shown at the end, and regularly through the talks. Everyone will have equal opportunities to ask questions wherever they are. Please turn your phones to silent, and that's all. So today, the last session of the day is called Prepared for the Unthinkable, and aims to identify lessons for our hospice sector from the recent awful Lucy Letby case. And I'm really delighted to introduce a very distinguished set of speakers and panelists for today's discussion. So on my left is Dr. Henrietta Hughes, who is the Patient Safety Commissioner. Sam Kyeremateng is Medical Director and Clinical Lead for Programme Development at St Luke's Hospice in Sheffield. Joanne Bosanquet is Chief Executive of the Foundation of Nursing Studies, and Paul Farthing is the Chief Executive of Shooting Star Children's Hospices. So we're going to start with a presentation from the Patient Safety Commissioner. Welcome, Dr. Henrietta Hughes.
Well, thank you so much, Toby, and thank you everyone for giving me such a warm welcome today. It's such a total pleasure to be here and a great honour. And I was reflecting on the work that I've been doing with the hospice movement, and also the personal experience that I had with my grandmother when she was at the end of her life, and the incredible, exquisite compassion that was shown to her and to us as her family. And I want to talk about why it's important to listen to patients and families. And when I've been speaking to people this afternoon, it really feels that that's really ingrained into your business as usual in the hospice movement. But I know that's not the case everywhere, and I think we'll be talking about that in a bit more detail on the panel. So my role is a new role. I've been in post for just over a year, and it's an independent commissioner role. And my main priorities are to seek improvements to patient safety around the use of medicines and medical devices, to elevate the voice of patients, and to champion the value of listening to patients. And as a GP, I was a bit surprised when that was written into my job description, because it would seem obvious that this is important, but clearly this isn't always the case. And my role is appointed by the Secretary of State, and I'm accountable to Parliament through the Health Select Committee. So I'm not an official, I'm not speaking on behalf of government. So the report from which my role was a recommendation, First Do No Harm, by Baroness Julia Cumberledge, described the health system as disjointed, siloed and defensive. Baroness Cumberledge heard from many patients who had been harmed through the use of medicines such as sodium valproate and Primodos, or through medical devices of pelvic mesh. And there were some themes that came through from this which were very loud and strong and resonated with the experience of many patients and families. That the voices and views of patients weren't taken seriously, they were dismissed, they were ignored, and as a consequence, harm continued. And I think that's a theme that we can take very much in the topic of this afternoon's panel, and how we can make sure that we're continuously listening and acting on the views and experience of patients and families and carers. So over my first year, I've been doing quite a lot of different things. First of all, listening intently to the views of patients and patient organisations and patient associations to understand where are the areas that need most attention and urgently. The top left-hand photograph is around consent, and I think consent is a real cornerstone of activity. And this is about people getting the right information to understand about the treatment that's being offered, but also the context of their life. And I was really pleased in the posters downstairs to see a poster that specifically was around what matters to me. And I see this as the fourth clinical sign, and how important it is that we're able to always look at the context of what matters to that individual at that point in their life. And I'm sure that's really vital to your work on a daily basis. The medicines in the middle, well, we have a lot of different medicines that we have concerns about, particularly medicines of dependence, medicines that can be teratogenic, that can cause harm to unborn children. And I've been working with regulators and with prescribers and others to look at the safety of those medicines in terms of how we can put controls and barriers into the processes to stop people getting harmed in the first place, but also to listen intently if people have concerns and want to raise them. The photograph at the bottom of the slide is a real good example of this. So sodium valproate, which is used for epilepsy and for some mental health conditions, is required to be dispensed using all of the relevant safety warnings. But you can see from this photograph, it was dispensed in a plain white packaging with no safety warnings and with no patient information leaflet. So I've worked with the government, I've worked with officials and with patient groups so that every single time a patient is dispensed sodium valproate, it's done in the original packaging. And this might seem sort of like the bleeding obvious to do, but up until only last month, if a GP did a prescription of 28 tablets and the box contained 30 from the manufacturer, the pharmacist would be required to open the packaging, snip off 2 tablets, discard them, and put the remaining 28 into a plain white box. So when you're thinking about the dispensing that's happening to your patients, particularly people who are going to be taking those medicines home, it's really worth thinking about what the implications are if we don't have that right safety information that goes with the medicine so that people can make the decisions about their care. The logo in the middle of the slide with the R's on it is about work I've been asked to do on redress options for people who've been harmed. Now, there are many different examples where patients have had harm, whether that's the infected blood, thalidomide, or variant CJD and vaccines. And with patients affected by sodium valproate and mesh, we're looking at possibly in the region of tens of thousands of women who've been harmed through the use of this medicine and their children affected. So it's really important that the advice that I've given to ministers is heeded in terms of looking at the needs of patients and thinking about how they can be supported. And I'll be publishing a report in the new year setting out the options that I believe are appropriate. And finally, when it comes to the communication between patients and families and those who are looking after them, where are the factors in terms of the hierarchies, the barriers to communication, and also the way that healthcare staff listen to the views and voices of patients? We've seen so many examples where this isn't working well. When it comes to the Lucy Letby case, the first thing I want to say is the massive condolences that I want to send to the bereaved parents. I think this is something which we're dealing with very difficult and very sensitive topics here, and we must always think about the impact on those who've been bereaved and those whose children have been harmed. And I don't want to talk specifically about the case itself, but I want to draw a parallel to a case that I was dealing with when I was a medical director at that very time. I was responsible for around 3,000 GPs in North Central and North East London. And a member of staff from a practice got in touch with my team with a concern about one of the GPs in that practice. And nobody prepares you for a situation when you're dealing with a big criminal investigation. And you have to think outside the box. But working with my team, the first thing that we did was we supported that member of staff, we protected their identity, and we rang 101. And what ensued was a very large police investigation, and the doctor was eventually charged, was convicted, of over 100 cases of sexual assault of his patients and was jailed for life. And I want to pay tribute to that member of staff who had that courage to raise this, to my team, but also to my team for being able to think the unthinkable and take the right actions, and to continue pursuing that case with other agencies, including the police, until the point when that doctor was convicted. And I think one of the things we deal with is that these happen very rarely, fortunately, very rarely. But one of the advantages that I think we had in my team at that time was that we were very well networked with other medical directors in NHS England, one of whom had been the medical director on the Harold Shipman case. And what was helpful with that was he had been through this, and he was able to share with us the steps that he took at that time, setting up a helpline for patients and families, support for staff, working with the police. And he told me at the time that the people who raised the concerns around Shipman were the undertakers. The undertakers noticed that Dr. Shipman's patients, when they went to their homes, the patients had died sitting up in chairs, fully dressed, which was so unusual because all the other GP's patients tended to be in their nightclothes, lying in bed. But did anyone take notice of what the undertakers said? No, because they were the undertakers. So what I would say is to keep your mind open to things that seem unusual, to reports that come to you that seem unusual. And for the staff in the case around the Countess of Chester, there was something about their courage in thinking the unthinkable and bringing information. And the way that they were treated is just so despicable in terms of them being required to make an apology to the very person who was harming the most vulnerable patients. So where do I see the gaps in that? I see the gaps in leadership. I see the gaps in listening to the patients, families, and to the staff, but also not working in partnership. If you're not looking outward and you're not meeting others, and that's one of the great values of a conference like these 3 days, that you're always seeing things that are different from the way you do them back at your home base. You're able to learn things, you're able to see with fresh eyes, and you're able to meet and connect with others who are doing similar roles to you, but maybe doing things in a way that you can both learn and share with each other. So I'm thinking about what I've heard from people at the conference today and how you're listening to the voices of patients and families and to the voices of workers. And I know from my previous job as the National Guardian for the NHS that the hospice movement has adopted freedom to speak up in the most wonderful way, not only in terms of the clinical roles, but all your volunteers in shops, in retail environments that we would never have imagined when setting up freedom to speak up. But there's also, how are you learning from incidents and concerns? How are you doing this in a way which is a just and learning culture, not a blame culture, one that creates that psychological safety that people do feel safe to speak up, whether it's a member of staff, a volunteer, whether it's a patient, whether it's a family. And particularly, if you're providing services at home, there are even more concerns that you might have around the safety of your patients, the safety of the medicines, the safety of the family members, potentially, if you've got medicines that could be harmful, and to think about how you are monitoring that in a way which is really reliable and also effective. The next thing I just wanted to touch on, because there's been a lot in the press around this recently, is around Martha's Rule. Again, a tragic example where a child died avoidably. And I've been working very closely with Martha's parents, Meripy and Paul. And one of the things which is, when any of you who've listened to Meripy on the radio or have read her account, her heartbreaking account of Martha's very sad deterioration and then death, is that the concerns that her parents had and that Martha had went unheard. They weren't listened to. The care was not escalated. And unfortunately, it got to the point where she was never going to be able to return from that, and she sadly died. And one of the things that I've found has been really interesting in doing the work that I've been doing around the Martha's Rule recommendations to the Secretary of State is that staff believe that patients don't really know whether they're well or not. Patients really do. know whether they're well or not, and their families really do. And how much by listening to and responding to the views, the voices and the concerns from patients and families, we can identify deterioration early, we can act on it, and we can use that information to keep people safe. I'm waiting for the Secretary of State to respond to my recommendations, and I'm hoping eagerly that it will not be too long before we're able to get this implemented across the whole of England. And just to be clear, the 3 things that I've said are, first, every inpatient in an acute or specialist trust should be asked on a daily basis at least, how are you feeling? Are you feeling good? Are you feeling okay? Are you feeling bad? Do you feel better or worse than yesterday? These might be really simple questions, but if asked in a formal way and then with the results acted upon, can identify deterioration in a patient a day or 2 days before their early warning score deteriorates. The next thing is I think that all staff should have a reliable escalation route if they've got a concern about a patient, and that might not just be the clinical staff, porters, cleaners, the people who see the patient every day and who really know. And then the final element, which is the Martha's Rule element, is that patients and family members should have access to that same escalation route. Bringing them in as an equal member of the clinical team, valuing and appreciating the voice of the patients and families equally to that of the staff. So I go back to what makes it happen. Well, leadership is at the core of all of this. This is a leadership intent to have safe systems and a safe culture, to elevate the voice of patients, to create that psychological safety, to listen intently to what people are saying and to act on it, and to work outwardly in partnership. Partnership with patients and families, yes, but partnership with the workforce, with the volunteers, partnership with the trustees, partnership with neighbouring and more distant organisations. And that's everything from me, so thank you very much. I'll join the panel.
Okay, so I'm just going to ask some questions of the panel. Do you think there is anything about palliative care in general or hospice care specifically that might make our sector, or obviously one of the organisations in it, more at risk to a case like this? Sam?
I think as a starter, it kind of feels almost impossible to understand the motivation behind these terrible kind of events and these terrible actions. But it would kind of seem to me that vulnerability is the key, and that, you know, our patients are extremely vulnerable. Whether they're any more vulnerable than, you know, patients in a children's high dependency unit, a palliative care unit, or elderly patients in a nursing home, I would find it difficult to say. But I think it's the vulnerability of our patient cohort that makes this a risk that we need to consider.
Joanne?
Yeah, thanks for that. Yeah, I agree completely. I mean, I'm minded to go back to my own professional and ethical code as a registered nurse, and that's why we have them as medics, nurses, AHPs. And it's really, really important for all of us to reflect and to have that space to reflect as people and as teams, because the level of emotional toil and physical toil, but emotional toil certainly, the more vulnerable our population are or person is, we don't get away with that scot-free. And so having a culture where you just get on with it, quick debrief, pull your socks up, stop sniffling, and good night's sleep, come back tomorrow and do it all again, that's not good enough anymore. So having that openness and transparency between yourselves to be vulnerable as staff as well is critical.
Cool.
Yeah, I think there's something particular about hospices that I think we just need to be mindful of. I think we ask a lot of our staff. They carry a lot of responsibility. They're sometimes going into situations where you might have a night shift or a weekend shift with relatively low levels of staff on board. You haven't got all the other organisations of a 24/7 operation, except for a small clinical team. And so we've got to be very mindful in those situations that they are part of a team and providing the right support for them, but be mindful that vulnerability combines without quite the same level of oversight. And so therefore it becomes even more important for each member of staff to not adopt a sort of bystander effect and go, it's not for me to make a comment on what someone might do. It becomes really important that they can ask and think, use the phrase, think the unthinkable. And it's a horrible situation to be thinking in a culture where you might be slightly mildly curious or suspicious of what another colleague that you work with, sometimes for days, weeks, months or years, does. But we've got to somehow give ourselves permission to be curious enough and to be prepared to ask and think the unimaginable, because once every very rare time these things happen. And we can't assume it's not going to happen to us.
So, Sam, I mean, building on what Paul says, we're encouraged to be curious, we're encouraged, and then we're encouraged to use data to check the empirical basis for any concern. And in a lot of the reports or the coverage that I read about the Letby case, people, obviously in a hospital setting, said, check for unusual mortality data. With the hospice sector, what would you recommend we look for?
I think it's a really, really challenging area, I think, if I'm honest. I'm not sure, and I'd be interested to see what comes through in Slido and the rest of the panel's views are. I'm not sure that we have robust enough data as a sector as a whole to be able to find those difficult signals. And I think there is good work going on across our sector. But if I give you an example, and I'm always a little cautious when I think about the examples that I consider, as hospices, as healthcare organisations, we all submit mortality or death data to the CQC. And actually, if we're looking at the acute hospital setting, the CQC will find those signals in hospital and in intensive care units. But because we're a setting where people die every day, actually, I don't think that there is a benchmark for that signal in hospice care. You know, and actually, as an environment where people die all the time, what's the difference between a mortality of 90% and a mortality of 20% in our inpatient units? So actually, if there isn't a structure within our regular reporting, and actually we don't benchmark with each other, how do we find the signals? Now I think there are signals, and Toby, please do stop me from talking. Anyone who knows me knows I will talk if I'm given a platform. But if we look at longitudinal data, that probably is internally the way that we can see in our own organisations where there are abnormalities. And that probably is where some of our strength lies. But then we also have teams who are really excellently involved, our clinical executives involved in our CD-LIN groups, so our controlled drugs, local intelligence networks, our pharmacy data, where we can look at that information. But it takes leadership, and it takes collaboration to recognise those signals.
Paul?
I just wanted to add on to this. I think this is an opportunity where I'm optimistic about the future, because although we don't have great data, listening to the session yesterday afternoon about artificial intelligence, the more that we can use data to spot patterns by asking neutral questions. One of the challenges is trying to find the right question of the data at the moment. And if you're not prepared to ask the question, you won't get the answer. And if that becomes the barrier, that's part of what I think I take out from listening to the Lucy Letby situation, is that you don't want to ask the really difficult question because you might find the answer. Whereas actually, if you can process a lot of data and spot which might be all sorts of different things. It might be about very serious incidents. It might just be you get more medicine incidents just before lunch because people need to eat better, or lots of different things that might explain behaviours by looking at the way that information can spot variations in patterns. And so I think there's optimism about taking what we can do and finding from a sort of position of neutrality.
Joanne?
And I'd like to challenge us a little bit on what we classify as data as well. It's not just, you know, AI, number crunching, quantitative. It's also qualitative data. And it's the data that comes in and out of our heads and brains and ears and eyes and, you know, every bit of our senses every single day. And so I would challenge us all to be looking much further back into our practice as people. Who are we? What is our identity? Why are we here? Why do we do what we do? You know, the whole Simon Sinek thing. I know it's been done to death, but you know what I mean? You know, our why. It's so much easier to say what and how, but why are we here? And that's where I'm going to come back again to reflective practice. Because if, you know, we can evaluate our practice in a 4th and 5th generation way, which is a participatory way. We can do realist evaluation, where our key lines of inquiry are probably not the same as the CQC. Perhaps, I don't know. Perhaps we need a conversation about that. But certainly the commissioners, NHS England, and I have to say they've been quite open to talking to us at the Foundation of Nursing Studies about the data they collect and why they do that, because we don't do that. We don't collect data that's not useful. So, you know, there are ways and means of doing that. There are ways around it, but it's about collectivism and collaboration and getting together in a matrix way to try and figure out what it is that you're trying to look at. So it's very complex, but you can do it.
Henrietta?
Yeah, thank you. I mean, I think about this as a speak up, listen up, follow up. So this is people speaking up, feeling safe to speak up, and for the leaders to listen up and follow up, and to think about what are the barriers that stop that from happening. So some of the things I've heard today are people who work in hospices are lovely. Everyone's lovely. Well, that's great, but it can also create barriers. It can mean that it's more awkward, that you've got friendships, you've got, you know, conflicts of interest perhaps. But there's also something about the other barriers that can exist. Because if we think about safeguarding, some people might choose to go and work somewhere where they get access to vulnerable patients. So it's just the difficult areas, isn't it, that are just difficult to get into. But then there's also, as I said before about the undertakers, the gut instinct. We have gut instincts that something's not quite right. And how do we get to a point where we feel safe to be able to speak up about something when we don't have any evidence behind it apart from our gut instinct? And that's what I would think for leaders to be continuously thinking about how they address that through their visible leadership, their communication and engagement with the workforce and with the volunteers.
I'm going to come on to culture, actually. I just wanted to share an interesting statistic that independent providers, which include, obviously, but not limited to hospices, that we have 21% of healthcare organisations. We account for 24% of freedom to speak up guardians, which rather
Amazing.
Reinforces what you were saying. But we only report 3% of cases. NHS trusts have 34% of healthcare organisations, 39% of freedom to speak up guardians, and report 92% of cases. I mean, Joanne, help me make sense of this data.
Oh, good Lord. Just put your stuff on Slido, please, for me. Help me. Well, I've thought about this a lot, and I suppose my immediate reaction is defensive practice, actually, or that perhaps much larger health and care organisations, you know, have much more complicated processes. They have their, you know, they'll have their audit, their governance, and this, that, and the other, and perhaps it's anonymised easier. Perhaps people feel more confident to, you know, to report something because it won't come back on them. So that's one way of thinking about it. The other way I've thought about it, which is I'm trying to positively reframe this, is that within the hospice sector, I would hope that there are good governance procedures that actually means it doesn't get to that point in the first place. And so by having a culture, I do have the two nodding, which is, I think they're nodding at the side of me. I'm hoping that is the case. But it is important that we don't don't compare apples and pears, but that we do look at these data because it is important and they are starkly different. So again, you know, don't trust everything you see on the face of it, but dig deep and figure out what it means by case. What does a case mean? You know, what was the context around those? And I think if you look at the work of NHS Resolution, they are doing some phenomenal proactive, preventative work actually around workplace culture at the moment within the NHS. And they've got some superb members of staff that can talk you through any concerns that you've got. So there's a lot of help out there to be able to dig deeper into these data.
And before we go deeper into culture, Henrietta, in your time in the role so far, have you come to a view yet about the specific assets and challenges that smaller healthcare organisations have when it comes to ensuring patient safety and having procedures and processes to protect it?
So I think it really depends on how the organisations are run. And one of the advantages to having a smaller organisation is you can have that senior, visible leadership. I've worked with a number of different organisations over my career, big and small. And even in very large NHS trusts, I've arrived and asked, who would you speak up to if you had a concern? And they'd say, oh, the chief exec, naming them by first name. And I'd say, oh, they've only been here for a few weeks. How do you know them already? Oh, I met him on the stairs, or I met her in the coffee queue. And so it's actually about that leadership intent to think of safety as a really core part of the role, and not to hive it off to a safety team or to another, role within the organisation. And I think having that connection to the front line, because people on the front line are the experts of knowing what works, what doesn't work, and how things could be done differently. Thinking about the phrase for this conference, thinking differently. There's something about continuously drawing up that experience and expertise from the front line. But I do think it's more about how the organisation wants to run. And small organisations spread over multiple footprint can actually be quite difficult to as well.
Thank you. Just coming to some of the questions that are coming in, people think we are too nice to harm. The narrative in society that many hospice workers are angels, working from a place of love. Joanne, do you want to share that? Do you want to share your thinking that you shared with us prior to the session about how that may have contributed to Lucy Letby?
Thanks.
Nice easy question for you.
Turn the recording off.
Or was that the bit you said you didn't want me to ask?
No, not at all. No, not at all. When you look back at other scandals and inquiries, we've had a number of them. They are regular and they're quite big. Mid-staffs is probably the one that most people remember. 260 recommendations. I'm not quite sure whether we've got through them all yet in 10 years, but they were there. But that was a huge deal, that report. And Ockenden, the list goes on. And there are some threads that run through every single one of those reports. And it's around workplace culture. It's about professional versus professional infighting, for want of a better phrase. But that defensiveness around practice. And it's still going on, and it goes on absolutely everywhere. And I was really lucky in the latter part of my kind of clinical public health career, because I worked in a team actually in North Central, North East London, where we had a matrix every day. So it didn't matter whether you were a doctor, a scientist or a nurse. It depended on what the context and what we were looking at. And so I didn't feel that for the first time in my nursing career. I didn't feel a subordinate to anybody. I felt proud and joyous and loved going to work, and I felt really energised and curious. And that was really important. But I do know people that have had that, and I've had it myself, even within nursing, where there's that awful phrase, I'm sure the nurses in here will repeat it with me, nurses eat their young. It is absolutely abhorrent, and I see it, and because I talk to people and people ring me because they know I'll listen and talk about it. So I think, you know, we've got to have these really, really honest conversations with each other, and we've got to dig deep into ourselves to say, what am I like to work with? What do people think of me? You know, I mean, I could go on, but you know, let's have an honest conversation about tribal behaviour. You know that.
Paul,
You know,
obviously one of your jobs as chief executive of a children's hospice is to create a culture of listening, culture where whistleblowing can take place, flourish. But you also lead a charity that needs to have a positive profile in the public, in the eyes of your public, in order to continue to raise the funds to provide your service. So, to share a question from Tom on the Slido, do you think there should be some form of regulation or tighter accountability for senior leaders around whistleblowing and how they've acted on concerns?
Well, I think that there's going to be lots of debate about whether we want more regulation, but I think we ought to go back to the fact that we started to talk about culture. You know, there's a phrase that culture eats strategy for breakfast, where it snacks on process. And I think that the danger in this debate is we start to talk about regulation and systems before we think about people and how we work and operate. And then we ought to decide, well, how do we find the right regulatory processes to sustain and support the right culture, rather than try and get the system to drive the culture. I think you're absolutely right. There's a dilemma for charities, small community organisations, about trying to be publicly to be seen to be both responsible and responsive and very mindful of our reputation in our communities, because you know, we're not the NHS. The NHS can go through and survive these scandals. Any one of these things could bring down a charity and end a hospice. But that's why one of the very important pieces of lessons that came out of the States looking at these sort of big reputational issues is that half of the damage in these situations is done from how you handle the situation as much as what it is. And in fact, you do more damage by mishandling the situation than you do from the original situation. So I think we've got to resist the temptation to try and keep it quiet and not deal with the issue. That doesn't mean you have to broadcast it, but you have got to be prepared to listen and deal with it internally. Focus on how you avoid it or you deal with it as an early prevention thing rather than let it fester and escalate, because that will make the problem worse. And then if it does become a public issue, you can demonstrate how you've been responsive and focused on parents, in my case, or patients, and keeping that as the primary balance. And I think one of the other bits in here is that there's going to be a balance in here about how you create cultures and listening environments and how you work and support health and well-being of staff and staff development, remembering that they're part of an ecosystem, they're not the whole ecosystem. Parents and patients are also part of this system. So how do we design the right environment for our staff that's also respectful and responsive to parents and patients? And sometimes those things might come into a bit of conflict, and we've got to talk those things through.
And Sam, a nice easy one from you to... there have been a couple of questions about, for you running a large clinical team at a hospice, how do you, if on the one hand we want to create a culture where people can raise concerns, on the other hand we want to avoid moral injury to staff who might feel to have any action questioned, let alone something as serious as this. Another delegate asks, is there a tension in creating open cultures where colleagues are able to raise concerns while also building strong, supportive teams? And you kind of recognize these questions, and I think we all also see that it was the disastrous lack of judgment by the management at the Countess of Chester on these questions that arguably was so harmful.
It's funny actually, in hospice, and I might be saying the wrong thing here, but as medics, sometimes we feel a little bit separate you know, from the functioning of hospice. As medics, there is actually, as we grow through our training, quite a significant culture of challenge. Sometimes that challenge can border on bullying. I have to say, not in part of medicine training, but there is a culture of challenge. It is quite normal to go into an education session or MDT and have to account for yourself. I do sometimes worry that we don't build that culture of constructive challenge in hospice, and that sometimes when we challenge, you know, it can kind of create a sense of, or a concern about bullying or pushing. And so there is something about building a culture in which challenge is absolutely normal. And if that is normal within the culture, then actually people will relax. And that actually there won't be moral injury, because actually this is normal. It's normal to be challenged as a clinical executive when you go to your board. It's normal to be challenged, and not in an aggressive or a hostile way when you're on your ward round. It's normal to be challenged in your MDT. Where I worry is where there is a kind of a space where we think, actually, I'm an independent worker. I shouldn't be challenged. I don't really have to answer to anyone. If I'm challenged, then someone is questioning my capability. That's not what constructive challenge is about. It's about, we're all... I was fascinated by Heather Richardson's talk yesterday, and about not deadheading our tall poppies, you know, and, you know, really trying to create an environment where we can discuss and debate. I think it is the rainbow of our professionals within our MDT that the varying opinions, in my opinion, as I've grown, you know, being challenged by a nurse who knows they're advocating for nursing, or a physio who's advocating for physio, or a medic who wants to know that we're following the guidelines in the way. It's that rainbow of professionals who can work in an MDT that allows us to work really effectively together, not being beige and not having no challenge.
Great. Henrietta, do you think that the new patient safety incident response framework would help hospice ability to learn from patient safety incidents?
Well, I'm hearing really good things about how organisations have welcomed the new PSERF, I think we can call it that, because it's actually giving people the choice to identify which incidents to investigate, and that the time isn't being used investigating the same things and coming up with the same results every time. So what I've been hearing, particularly from NHS trusts, is that they're able to start looking at some of the themes. They're able to then get under the hood, as it were, to look at what are the causes of those, and then they can start putting some barriers and controls in place to prevent them from happening again. So I think there's something about how you use PSERF to help you, how you work with others to see how they're doing it. It's new, but also something about the training, so the curriculum that goes along with it, not for the patient safety teams, but for everyone. And that's what I'm really interested in, particularly for execs and non-execs, having the skills and knowledge about safety, so that when the themes are coming up, they're going to be interdependent. It's going to link to staffing, it's going to link to procurement, to estates, facilities, etc., because we can't really separate safety out. Safety comes into everything that we do. So I think there's something about how you're learning from it, but also how you can share that learning with others. So that's a really exciting area as far as I can see.
One final question for you, Henrietta, but one question I haven't asked yet, which has been picked up on by a lot of participants on Slido. If it's still the case that over half of the complaints referred to the Health Ombudsman relate to end-of-life care, how can we amplify the findings of these complaints to direct action at a national level?
Well, I mean, I have a problem with the way that complaints process works, because I think that it puts a burden onto patients and their families. It requires them to pull together the evidence. It separates the patients and their families from the very staff who've been looking after them, and it creates an oppositional stance. And so I've called on the Department of Health and Social Care to overhaul the complaints process, and I'm much more interested in a more restorative approach, as they've done, for example, in Merseycare in the UK, but also in New Zealand, where they ask a series of questions. They say, who was harmed? What do they need? Who is responsible? What are their obligations? What can we learn from this, and how can we stop it happening again? And I think that would really transform the way that patients and families are able to give feedback without having to make a complaint, but also not to have to be, have their harm compounded through going through quite an unhelpful and quite a cold process. But then there's also something about why these complaints are going to the Ombudsman. And in my previous role at NHS England, I was signing off a lot of the complaints from primary care. And as soon as I saw the response letter that came back from a practice, I learned a lot about that practice. Some complaint responses would say, I'm so sorry about the experience that you've had, and then they would break apart the complaint letter into the individual areas of concern and respond to those in turn. There would be learning, there would be respect, there would be so much compassion in that complaint response, and it would give me as a medical director a real, I could breathe out. But others were very different. They would say, well, if you want to complain about me, I also want to complain about you. I'd be like, what? And I was sort of thinking to myself, have they ever been on a course of how to write a response to a complaint? Have they contacted their defence organisation to help? And yes, of course, we can all have situations where we're frustrated. But at the same time, there's something about that listening and that learning and responding. So one of the things I would say is that if you haven't got the support from the Ombudsman's office already in terms of looking at the complaint standards, in terms of the courses that they do for responding to complaints, then I would really encourage you to do that, because what we don't want is a situation where people feel that they haven't been listened to and that they have to go somewhere else. They have to go to the Ombudsman or to the press or to their Member of Parliament. Because I think that the more we're able to reconnect the patients and families, the loved ones, with the teams who look after them and maintain that relationship all the way through, I think the fewer situations where people will have had compounded harm and the complaint will end up at the Ombudsman. Thank you.
Just going to shoot fire some, because I know we're slightly overrunning, but whoever's in charge here, if it's all right, we'll take a few minutes, because there's some great questions. So I'm going to quick fire some questions. I'm going to come back to all panelists for some closing reflections. Some nice, easy ones. Sam, is the lack of listening to clinicians in the Letby situation a warning to hospices moving away from having clinicians on senior management teams?
Yes.
Yeah. Hang on. There was... Joe, to what extent do you think racism plays its part in the Lucy Letby case?
Right, so, yes, thanks for that. Again, on social media, and it's not, obviously it's not the whole truth, nothing but the truth, but the activity on social media following the conviction, but obviously then when people could talk about it openly and freely, was that Lucy Letby was a white, young, kind, middle-class paediatric nurse, and so she just couldn't have done that. And the criticism, quite rightly so, was, well, if she'd have been black, would she have been left so long to do this? So I think it's a very complex question. It's loaded. But my intuition is, yeah, because we don't want to see that, do we, in anybody, but certainly a white, young, kind paediatric nurse who loves a job, it's who actually masked so beautifully that she had everybody fooled. So yeah, but I do believe that we need to think about that much more cleverly.
Paul, are we complacent as a sector, do you think?
I don't think we're complacent, but I think this is a moment for a bit of reflection that just gives us a checkpoint that says You know, we, as I said at the beginning, we place a lot of responsibility on our staff, and are we both supporting them to make sure that they are mindful of that, and that that they have, within their power, they have a huge amount of influence over parents, a huge amount of authority that they carry. And to make sure that we're not sending mixed signals apart from anything else, I think it's important that we just, as I say, take a moment of reflection and go, are we acting in the very best interest, and are we asking the right questions of ourselves and each other's to make sure that we are doing the very best for, in my case, for Children's Hospice, for parents, because that's what it comes down to. That's the thing that binds us together. And I know that's what binds everyone in this room, is that we're there for families. So families rightly ask us very difficult questions sometimes. Perhaps we need to ask the questions before they have to.
Good. Thank you. So I'm just going to ask every panelist to end maybe by giving 2 pieces of advice, perhaps one do and one don't, to the audience here, in terms of 2 bits of advice to what you can personally do as leaders, what our audience can personally do as leaders to promote and enhance patient safety in a hospice setting.
Well, I think I would say do your best to listen up and do your best to follow up, because you don't know what it is that you're being presented with. It might be nothing, it might be something, but it gives that member of staff that confidence that you are really valuing what they're saying. And what I would suggest you don't do is brush something under the carpet, because it will come back, and that's where, as Paul was saying, that's the scandal. It's how you deal with something, not what you're dealing with.
Sam?
I'm going to say 2 do's, if I can. So I think ensure we have a culture of giving and receiving constructive challenge. Our MDTs, our morbidity, mortality meetings are one example. Clinically, our boards and our governance committees are another example. And challenge, if challenge is resisted, ask why. Find a way to celebrate and engage our tall poppies. And then also thinking about that benchmarking issue, the other do, I think, is let's actively pursue PSERF. Seems like a really interesting opportunity for us to implement and actually have some of these things in the front of our minds. And also, why aren't we benchmarking? Who are we waiting for to benchmark for us? Why aren't we benchmarking ourselves against ourselves? We know what happens in our sector.
Thank you. Joanne?
I'll do 2 don'ts then, shall I? We've just had a great session before this one with some colleagues, including Jess, and Jess said to me, don't ignore your intuition. And I think my other one is don't be invisible. Be visible. Walk your walk. Walk the talk.
Thank you.
I better do a do and a don't just to balance it out. So my do is, you know, don't ignore the known unknowns. Sometimes it can be very tempting to leave it on the desk. I think it's the point you're making, Henrietta. Just to, you know, you look at it and go, well, there's just a small thing here. But actually, once you've identified it, you have a responsibility to follow it through and to satisfy yourselves as leaders in an organisation that there's nothing to it, or that you've made a change or you've adjusted your behaviour. And the don't ever assume it can't happen to you.
That's a great way to end. So thank you so much, Paul, Joanne, Sam and Henrietta. Thank you.